Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and whether you're here as a nursing student, getting ready for the NCLEX, or getting ready for nurse practitioner school, I hope this series is able to help you. In this pharmacology series, we are going to cover essentially everything you need to know as a nurse to pass your pharmacology course. You can download the notes that we use in this lecture from our website, and it's highly recommended that you use them, follow along, and add your own comments on the extra items that we covered in this lecture. We're going to be going through neurology today, and we have a lot to cover, so let's get started. Most of the medications that treat the diseases that we're going to start with, and we're going to start with some progressive diseases such as Alzheimer's and Parkinson's disease, these do not cure these conditions. Unfortunately, all that we have available today as of the recording of this lecture in mid-2023, all that we have available to us is to manage the symptoms and slow the progression of these diseases. We're going to begin with Alzheimer's disease or dementia of Alzheimer's type. And the drug class that we're going to start with is acetylcholinesterase inhibitors. So acetylcholinesterase, we talked about this in a previous lecture if you watched the one on cholinergic drugs. Acetylcholine is the primary neurotransmitter of the cholinergic system. And acetylcholinesterase is responsible for getting rid of acetylcholine. By blocking that enzyme, by blocking acetylcholinesterase, we block the body from getting rid of acetylcholine, thereby increasing the amount and effects of acetylcholine. What drugs are we talking about? These will be donepezil, galantamine, ribostigmine, and several others. What is it used for? It's used for Alzheimer's disease. Now, these drugs have a little bit of a side effect of GI symptoms, usually upon starting the initial treatment. So a good patient education point, especially for nursing and NCLEX, would be to educate your patient that these symptoms may develop at first, but they will get better as you progress with your treatment. Physostigmine is another drug in this class, and we talked about it in the previous lecture in regards to anticholinergic toxicity. However, it's also used to treat myasthenia gravis, which is another neuro disorder. This is the only drug that we're going to talk about for the treatment of myasthenia gravis. The next drug class we have are dopaminergic agents, and at this point, we're moving on to Parkinson's disease. Dopaminergic agents include levodopa-carbidopa, and this is used to increase dopamine synthesis. Our goal of treatment, like in Alzheimer's disease, it was to increase the acetylcholine level. Now, with Parkinson's disease, the goal of treatment is to increase our dopamine level. So how does this work? It increases dopamine synthesis or creation in the body through various methods that I wouldn't expect you to have to go into at the RN level. The adverse effects of this drug, there's quite a few: nausea, vomiting, dyskinesia, orthostatic hypotension, and psychosis. This is considered the most effective medication for the treatment of Parkinson's disease. This doesn't mean that everyone's going to get placed on it. However, this is considered the most effective treatment. This medication may have something called the wearing off effect, which is where a patient's symptoms begin to return before it's time for their next dose. And usually in that case, we move their doses a little bit. We change their dose timing to make it a little closer together. I would educate patients to take this medication with food to reduce the incidence of nausea. The next drug class we have, again, Parkinson's treatment is about increasing our dopamine effects, and the next one is dopamine agonists. The dopamine agonists are apomorphine as well as some others. The mechanism of action, we do know that they activate dopamine receptor sites. However, beyond that, we don't know exactly how they do that. Adverse effects of this medication: constipation, nausea, dizziness, a few other things. When you see that insomnia on there, remember that means to tell the patient to take it in the morning, or to educate your patient on non-pharmacological insomnia interventions, turn down the lights, turn down the temperature, things like that. And again, this medication is for the treatment of Parkinson's disease. The next drug class we have are MAO-B inhibitors. If you watch the mental health lecture, we covered MAO inhibitors or MAOIs, and those block monoamine oxidase, MAO. Well, monoamine oxidase is responsible, MAO-B specifically, monoamine oxidase B, is an enzyme that's responsible for getting rid of dopamine. Again, we're still talking about Parkinson's. Our goal in treatment is to increase the dopamine level. So we're going to inhibit MAO-B. We're going to inhibit monoamine oxidase B from getting rid of dopamine, thereby increasing our dopamine effects. What is this used for? Again, Parkinson's disease. What does this cause? It causes insomnia. Educate your patient to take this in the morning. Also, like we saw with monoamine oxidase inhibitors in depression, monoamine oxidase B or MAO-B inhibitors also have that issue that they cannot be mixed with tyramine-containing foods. So patient education, educate your patient to avoid tyramine-containing foods, educate your patient on what are tyramine-containing foods, and finally, for patient assessment, this is a fair question. What would you look out for signs of an interaction with tyramine? That would be a hypertensive crisis or just generalized hypertension. Also a note, MAOBs, just like MAOIs, interact with a lot of other medications. We're going to point out specifically most of your antidepressants, such as SSRIs and TCAs, this medication class will interact with it. The next one is a drug class called COMT inhibitors, which is catechol O methyltransferase inhibitors. You definitely don't need to know what that stands for, but just know that COMT does the same thing essentially as MAOB in that it helps the body get rid of dopamine. By blocking COMT, I'm going to increase my effects of dopamine. Again, that's our goal of treatment here in Parkinson's disease. This specific medication, the medication here is anticapone. This medication is often added as an extra ingredient inside of levodopa-carbidopa, and that's meant to address the wearing off effects. We may also add it to the patient's treatment regimen with other drugs, such as the dopamine agonist, again, to address that wearing off effect. Finally, for Parkinson's disease, we're going to talk about Benztropine. Again, we already covered this in a previous lecture, but let's go through it real quick. This is an anticholinergic, and how it helps specifically with Parkinsonism is not 100% understood, but it does help specifically with Parkinsonism and secondary Parkinsonism EPS. And what that means is the tremors. So that's what it's used to control. Again, symptomatically, it's used to manage those symptoms. And secondary Parkinsonism is also part of the constellation of symptoms called EPS. And this would be one of the drugs used to treat that symptom development. Adverse effects of this drug are anticholinergic effects. If you don't know what those are, please go back to the lecture where we covered cholinergic effects and anticholinergic effects, because there's a ton of test questions that could be asked about that, whether it's in your nursing program or on the NCLEX. Next, we have a drug class called immunomodulators, and now we've moved on to multiple sclerosis. Immunomodulators has a number of different drugs. There's interferon alpha and interferon beta. Interferon alpha, we're actually going to talk about in infectious disease. So right now we're going to talk about interferon beta. The mechanism of action of how it works is not understood. However, interferon beta is used for multiple sclerosis. Interferon alpha is used for various severe viruses. These drugs are all given parenterally only. So a patient education, a good wrong answer would be make sure you take this with food. Well, that doesn't make any sense because this isn't an oral medication. So again, if you do see that a drug is taken parenterally only, since the vast majority of drugs are PO, definitely memorize which ones are parenterally only. These drugs have a pretty common adverse effect of causing flu-like symptoms, as well as hepatotoxicity. Questions here would be, what would you look out for? You educate your patient they may develop flu-like symptoms. Sometimes we do pre-medicate the patient with something like an NSAID, ibuprofen, to help prevent that from developing. Hepatotoxicity, again, we've covered this multiple times. Make sure you know that means to look out for signs of AST, ALT, jaundice, things like that. Make sure you avoid it in patients with liver diseases, hepatitis. Not only that, you would also consider take it under consideration if the patient has alcohol use disorder or a recent acetaminophen overdose. All of those are toxic to the liver, and this drug is as well, so we wouldn't want to pile on one problem on top of another. Other drugs that are used for multiple sclerosis include monoclonal antibodies, which is a whole massive class of drugs. In fact, I think the absolute largest class of drugs today is monoclonal antibodies. We'll talk about that in a separate lecture. We also sometimes use immunosuppressants. Keep in mind, multiple sclerosis is considered an autoimmune disease. We don't fully understand how it develops, but we do think that it is an autoimmune disease. Moving on from a few of these diseases as we continue our discussion on neuromedications, next we're going to talk about skeletal muscle relaxants. These are relatively commonly used drugs, baclofen, cyclobenzaprine, and a few others. Mechanism of action is not 100% understood on how they work, and each of these do work a little bit differently. What do we use it for? We use it for spasticity, and we use it off-label for a few other indications. These drugs do have an adverse effect of CNS depression. Most of them do have the same effects as a GABA agonist, meaning that they slow down CNS processing, which leads to sedation, weakness, drowsiness, fatigue, etc. Cyclobenzaprine specifically will also have anticholinergic effects. You should educate your patient to not mix this with alcohol or any other CNS depressant, since this is already kind of a CNS depressant. Another medication that we have for spasticity is maybe dantrolene. Dantrolene works by suppressing the release of calcium. Depending how much you remember of your study of anatomy and physiology, calcium is the #1 most responsible electrolyte or ion in terms of muscle contraction and muscle movement. By suppressing the release of calcium, we can depress that muscle movement, that contraction, that spasticity. And that's what this medication is used for. It's also used for malignant hyperthermia, which we'll talk about separately. Adverse effects primarily be weakness, again, because it doesn't interfere with that calcium, which is required for muscle movement. It has a black box warning for hepatotoxicity, and patients should be educated, again, to avoid taking alcohol or any other CNS depressant along with this medication. Another thing that we do use for muscle relaxants, in addition to the actual muscle relaxants and sometimes dantrolene, is going to be benzodiazepines, which we're going to discuss in just a minute when we get to seizure medications. One more drug class I want to talk about here. It's used for spasticity as well as several other things. This may or may not be covered in your nursing pharmacology curriculum, but the medication is Botox or botulinum A toxin, also known as onabotulinum, very commonly known as Botox. Clinics for this are popping up everywhere, have for well over a decade now. How does it work? It inactivates muscle pathways. And what is it used for? We use it for a whole bunch of different things. We use it for migraines, overactive bladder. Everyone knows we use it for aesthetics, cosmetic reasons. We also use it for spasticity. The adverse effects depends completely on where you're giving it and what you're giving it for. Do educate your patient that the effects of the medication, as well as the adverse effects of the medication, can have an onset from days to weeks, even months. So if a patient comes in several months after Botox, they can still be developing the adverse effects of that medication. Now we're going to move on to medications for seizures, which definitely starts with talking about benzodiazepines. Benzodiazepines is a very large class of drugs, also known as GABA agonists. This includes things like lorazepam, diazepam, alprazolam, and a whole bunch of others. These drugs are our first-line agent, universally accepted for a patient with an active seizure. How does it work? It is a GABA agonist. GABA, we spoke about previously, is an inhibitory neurotransmitter. Think of it as the brakes of the brain. So if I give you more GABA, then I'm pushing harder on the brakes, which is going to slow things down in the brain. If someone's having a seizure and the electrical pathways are firing like crazy, obviously slowing things down, that makes sense how it helps. What do we use this for? This is a pretty broad class of drugs. We use it for seizures, insomnia, anxiety, sedation, muscle relaxant. We use it for a whole bunch of different things. That list isn't even complete. Adverse effects, well, since it's a sedative, it's going to cause sedation. It's also going to lower our blood pressure. It's also going to lower our respiratory drive. You must assess your patient before and after administration for their level of consciousness, their alertness, because it is a sedative. You need to assess their blood pressure because it will decrease it. You also need to assess their respiratory drive, not only their rate, but their depth and chest movement as well, because again, respiratory depression doesn't only mean a slower rate, it also means lower overall inner movement. So that could be from just starting to take shallow respirations. These do have a black box warning, as do all controlled substances, that they can cause addiction and dependency and has a risk for abuse. Another black box warning is do not mix this with other CNS depressants, since it is already a CNS depressant. If we mix it with another one, we're going to get too much effect. This is a controlled substance, a Schedule 4. Patient education, we already said, relates to that black box warning. Do not mix it with alcohol or other CNS depressants. There is a reversal agent out there. It's called flumazenol, and it's meant to reverse benzodiazepine overdoses. It is not very commonly used, and there's not anything else that I would expect you to have to know about that. Just know that we do have a reversal agent for it. It's called flumazenol, and we would give it if someone has a benzodiazepine overdose to the point that it's causing too much CNS depression, too much low blood pressure, or too much respiratory depression. Moving on for seizures, the next drug class we have are the hydantoins, and one drug in this class is phenytoin or dilantin. Another one is fosphenytoin or Cerebrex. Fosphenytoin essentially converts into phenytoin once it's metabolized in the body. So these drugs are essentially the same thing. How does it work? It prolongs sodium channel inactivation, and by prolonging the time of inactivation, it stabilizes electrical impulses, and we know in a seizure, the electrical impulses in the brain are going haywire. This slows them down. What is it used for? It's used for seizures. Adverse effects of this are dysrhythmias and low blood pressure. Remember, if you see those adverse effects, that means you need a nursing action. You need to assess the blood pressure before and after. It means you need to have the patient on a monitor, and it means you need to assess the patient for underlying history of dysrhythmias, AFib, anything like that. Remember, everything on here can be a potential question, especially NextGen NCLEX. It's not going to be straight up, what would you monitor for dysrhythmias? It would be which of the following patients most needs to be on an ECG monitor or something like that. And if they're on this medication, that would be a good answer. This does have a black box warning that you should give it slowly via the IV route, because if you give it too fast, it can have significant, including fatal, adverse effects. This can reduce a patient's vitamin K level. Vitamin K, if you remember from anatomy and phys, is related to our coagulation pathway. And by reducing vitamin K level, it can cause bleeding. How do we treat that? We educate the patient to increase their vitamin K intake. That's going to be spinach, green leafy vegetables, things like that. Or we may have them supplement with vitamin K. This medication is toxic to the local tissue in the event of extravasation. So we've seen this a few times already, where a medication, if it leaks into the local tissue instead of going IV into the vein, if it starts to go into the tissue, it can cause a problem. This is another example of one of those medications that causes the problem. Patient education on this is that it can decrease the effectiveness of your oral contraceptives. On the flip side, it's also toxic, teratogenic, toxic to a pregnancy. So that's a bad thing. That A, it's going to make the person's oral contraceptive not work as well. Plus, if now that it made them more likely to become pregnant, if they do become pregnant, it's toxic to the baby. So what do? We need to find an alternative medication method of contraception if it's a female of childbearing age. And we also need to educate them not to become pregnant on this medication. Another drug class we're going to talk about are these succinimides, and the drug here is ethosuximide. I believe that's the only drug in this class. And this drug is used for one thing. It's used for absence seizures. We're not going to get into the whole pathology and patient assessment of what are all the different types of seizures, but absence seizures is one subtype of seizure, and this drug is used specifically to treat that. How does it work? It blocks specific calcium channels, which cause an increase in the seizure threshold. You'll see that concept quite a bit in pharmacology and in A&P in general, if you haven't already seen it, where we increase the seizure threshold, or we increase the cough threshold. And what that means is it takes more to go wrong for the seizure to occur. So if I give you this medication, it makes it harder for you to get a seizure, because the threshold for where that seizure trips, and now we're in a seizure, moves up. So now it's even a higher hurdle for that to happen, making it less likely for the patient to develop a seizure. Continuing with our drugs that are used for seizure disorder, we have barbiturates. A drug here is phenobarbital. This medication, just like benzos, is a pure GABA agonist. It increases the effects of GABA. Again, GABA is GABA-aminobutyric acid, and that is the brakes of the brain, also known as an inhibitory neurotransmitter. What is it used for? It's used for seizure disorders. This one is also used for sedation, just like benzos. However, this is a little bit less sedating, or this medication is a little bit less sedating than other barbiturates. However, barbiturates in general are considered very, very much sedating. These are controlled substances. Again, just like benzos, they're Schedule 4. They have this. They do have an issue with causing the vitamin K problem, just like we saw in 2 medications ago. And same education, do not take it with alcohol, because that would cause way too much CNS depression. And additionally, this can decrease the effects of your oral contraceptive. So again, what would an NCLEX question be here? It can be anything related to what are the patient education points for how to avoid pregnancy, or what are additional considerations or patient populations that this may not be ideal for, female of childbearing age. Next drug class we have are the Valproates, which includes valproic acid. We've seen this before because we talked about it in the mental health lecture in terms of a drug for bipolar disorder. The mechanism of action here is that it prolongs sodium channel inactivation, plus it's a GABA agonist. This drug has 3 black box warnings as well as 3 indications. Let's start with the indications. It's used for seizures, it's used for migraine prevention, and it's used for bipolar disorder. It has 3 black box warnings: hepatotoxicity, highly teratogenic, and pancreatitis. Again, each of these, there's a lot of test questions that you can come up with. How would you assess for adverse effects of valproic acid? Well, that could be the adverse effects of hepatotoxicity. So that could be elevated AST, ALT, that could be jaundice, that could be liver enlargement. Highly teratogenic, you would what labs would you assess prior to giving this drug? Well, AST, ALT, we already said that. Plus, you would want to check an HCG to make sure the patient's not pregnant before starting this medication. Finally, pancreatitis, a lot of signs and symptoms here that you would look out for. And there's a few labs as well, such as amylase and lipase, that you would assess for pancreatitis adverse effect of this medication. The next drug class, I'm not 100% sure how to pronounce it, so I'm not going to butcher it. I'll let you guys figure that out. But the drug here is carbamazepine, also known as Tegretol. This medication, again, works the same as the last one by prolonging sodium channel inactivation, not the last one, but a few ago. The hydantoins, by prolonging sodium channel inactivation, it lowers how quickly things are moving around in the brain, which again, if a patient's having a seizure, we want to slow things down. What do we use this for? Seizures and bipolar disorder. Again, you're noticing a lot of overlap between the medications for seizures and the medications for bipolar disorder. You're going to see that again with another one as well. Adverse effects, this can present neuro effects upon start of treatment. And neuro effects is very vague, and it's right like that specifically because every person is going to have a little bit different neuro effects. Some people will be agitation, it could be drowsiness, it could be dizziness, it could be headache, it could be confusion, it could be anything like that. Again, same issue with vitamin K, same issue with that it decreases the effectiveness of oral contraceptives. And this one does have 3 black box warnings. The first is for dermatological disorders, that is Stevens-Johnson syndrome, SJS, or TEN, 10, which is toxic epidermal necrolysis. Another thing, aplastic anemia, and another thing, agranulocytosis. What would be a fair test question they can ask on this? What would be the most important lab to assess for prior to administering this medication to a patient? Well, you may be wanting to assess their HCG to make sure they're not pregnant. Another thing that you would want to assess is afterwards, check for the adverse effects of this drug, and that would be a CBC to check for aplastic anemia and agranulocytosis. The next 2 medications we have are considered the better ones for a patient that is a female of childbearing age. As you notice, all of these medications are either teratogenic, flat out, not a good idea, or they're at least not ideal for a patient that's a female childbearing age. However, we do have the next 2 coming up that are the better choices. The first one's going to be lamotrigine, which is also known as Lamictal. The mechanism of action, once again, prolongs sodium channel inactivation. However, this one also blocks specific calcium channels and it blocks glutamate. What is this used for? Seizure disorder and bipolar disorder. And we actually covered this in the bipolar lecture. This and the next one, Keppra, are 2 of the best options for pregnancy for a patient that's having a seizure disorder. This medication also has the same black box warning as the previous one for SJS and 10, so definitely look out for dermatological symptoms. A good test question here would be, in which patient would be most important to assess to do a thorough skin assessment? This would definitely be a good answer for that. The next one we have is levetiracetam, which is Keppra. Mechanism of action here is not completely known, but this is actually today one of the most popular seizure medications. What is it used for? Seizures. Again, it's one of the best options for pregnancy, and it's one of the most commonly used in general. Another medication that we have is gabapentin. The mechanism of action for this one is unknown, but we do use this for a few different things. We use it for seizures, and it's also labeled for post-herpetic neuralgia. I will tell you, this medication, however, is extensively used for other things such as neuropathic pain. Another drug that we have is topiramate, which is Topamax. The mechanism of action here is that it prolongs sodium channel inactivation, blocks specific calcium channels, blocks glutamate, and is a GABA agonist. Basically, it does everything of all the mechanisms of actions of any of the seizure drugs. This puts all of them together in one. This medication is a pretty serious medication. It has a lot of considerations prior to starting this on a medication. And usually it's only started by specialists who have a lot of experience dealing with this medication. It does have several adverse effects, including CNS effects. Again, we said that could be dizziness, headache, confusion, fatigue, lethargy. Every person's going to be a little bit different. It does have an adverse effect of weight loss, not nearly as much as the drugs that actually cause weight loss, like semaglutide, but this does have that as a known side effect. Obviously, for most people, that's considered a positive. And it has, again, like I said, several other adverse effects as well. This is also used off-label for bipolar disorder, eating disorder, tremors, and more. Patient education for this medication is that it can decrease the effectiveness of oral contraceptives that we've seen over and over. Let's cover one more medication for seizures, and that is pregabalin, also known as Lyrica. The mechanism of action here is that it inhibits multiple neurotransmitters such as epi, glutamate, serotonin, and more. What is it used for? It's used for fibromyalgia, actually more than seizures, but it is also labeled for seizure use as well as neuropathic pain. This does have several adverse effects, and these are, again, pretty distinct adverse effects. And anytime you see those one-off adverse effects, I would expect to see it on a test. Something like visual disturbances is pretty uncommon, so I would know that. Pregabalin causes visual disturbances. It causes peripheral edema unrelated to heart failure, which again is pretty unique. So I would know that. It can cause weight gain, and again, like almost all of the seizure medications, it can cause a patient to have effects related to their neurostatus. Let's go through a few general concepts about treating a patient with seizures, then we're going to move on to sedation. When we treat a patient with seizures, first of all of these medications, we start off slowly, meaning a low dose, and when we do reach our target, we then keep them on it, and we come down also in a slow manner. A patient, for example, if a patient is taking a SSRI and they've been taking it for 5 years and now they want to stop taking it, no problem, we'll slowly come off of it. Hopefully they're now able to handle their mental health without the assist of a medication. Seizures a little bit differently, because in seizures, a patient can very often be on a medication for 15 years, no issues, but then when they start to come off of it, they can redevelop seizures. Obviously, this is something that is done in consultation with the neurologist, and it's done very carefully and monitored very closely, but generally speaking, if and when a patient does come off their seizure medicine, it must be done very slowly and very carefully. Another thing to keep in mind, if a patient becomes pregnant, they're female childbearing age, and they become pregnant while taking this medication, or any seizure medication, they're recommended to take folic acid. Folic acid is a common supplement that's taken for pregnancy. However, it's extra recommended for a patient taking any anti-seizure medications, considering a lot of these medications do have not the best effects on a growing fetus. Now, the next point is really important to understand. Anytime a female of childbearing age who has a history of epilepsy and is on their medication and it's well controlled, and now they become pregnant, a decision must be made whether or not to keep their medication, change their medication, or stop their medication. And it's not as simple as this medication is teratogenic, they're pregnant, stop taking it. It doesn't work that way, because you know what else is bad for the pregnancy? Seizures are bad for the pregnancy. And if we suddenly stop taking the seizure medications, the patient is likely to develop seizures, and that can be just as bad, if not worse, for the developing fetus. For that reason, if a patient becomes pregnant, depending what medication they're on, depending what their history is, depending whether there's safer options, depending on whether they've had seizures in the past, all of this is done in consultation with the OBGYN and the neurologist to determine what's the best course of action. But I want to be clear, it's not going to be a simple medication teratogenic, I'm going to stop taking it because I'm pregnant. No, because seizures are also, they're not technically teratogenic, but for all intents and purposes, yes, they are. Finally, we do have something that you may see on a test or an exam, non-pharmacological interventions for seizures, and that is the ketogenic diet. It's not pharmacological, so we're not going to go any further into it than that. Again, all of your assessments, how to assess for a seizure patient, not to put objects in their mouth, safely lower them to the ground, padding on the bed rails, all of that, we're not going to cover in pharmacology, but make sure you know that definitely for NCLEX or any other exams. Next, we're going to move on to medications that are used for anesthetics or sedatives. So we're going to start with Diprivan, which is propofol, which is by far the most popular sedation medication in the United States. How it works exactly, we don't know, but we do know that it does promote the release of GABA. Once again, GABA is that inhibitory neurotransmitter. It's like pumping the brakes in the brain, and by pumping the brakes, I'm going to slow down the brain activity to the point of sedating the patient. We use this for both anesthesia and sedation. Those are two different things. Be very clear, anesthesia and sedation are not the same thing, but this is used for both. The adverse effects of this medication class are respiratory depression and hypotension, which means you must assess your patient before treatment, during treatment, and after treatment for respiratory depression and for hypotension. No excuse not to do that. This medication is IV only, and it can be given IV push or IV infusion. You'll see it in both modalities depending on the patient situation. There is something called propofol infusion syndrome. I would definitely know this if you're taking this, watching these videos for school purposes. And this can occur, and it involves acidosis, cardiac and renal failure, and rhabdomyolysis. Any patient who is on propofol infusion is going to be monitored for this adverse effects. It's not that common, but it is pretty serious, and it is a known issue. So we do carefully monitor any patient who is getting propofol, especially if they've been on it for more than a few days, we want to keep an eye to make sure that these adverse effects are not happening. Another drug that we have for anesthesia is etomidate. Etomidate is a relatively problem-free drug. It's used for induction of anesthesia. It's used excessively in the acute care setting and in the OR setting. It is given by IV only. It's given just to induce anesthesia, and then another drug takes over to maintain anesthesia. This drug alone does not maintain anesthesia for a long duration of time. The next drug that we have is ketamine. Ketamine is a NMDA receptor antagonist. It is also known as a dissociative anesthetic. This medication is used to induce anesthesia. It's also used for pain. The adverse effects of this drug, this patient can have a lot of adverse effects, specifically something called, the layman's term for that would be a K-hole, where the patient becomes completely disassociative. They don't process anymore what's going on in their body, which in the case of pain is generally what we're going for. This is a controlled substance. It's a Schedule 3. So this is higher than the benzos and barbiturates that we talked about in this lecture, because this is stronger, more potent, and it has a more powerful mechanism of action. Unlike other medications, this one is more likely to increase a patient's heart rate and blood pressure, increase a patient's heart rate and blood pressure, because what were the others? The benzos and the barbiturates, and propofol, they were going to decrease a patient's blood pressure. This one is more likely to increase it. That's definitely fair game for a test, whether it's at the RN or the NP level. In low doses, this medication is also used for pain. Higher doses is where we use it for anesthesia. I wouldn't expect you to have to know that, but just as a practicing RN, know that we're not using the same doses when we're trying to use it just for pain versus when we're trying to fully induce anesthesia. Keep in mind, this medication not only is used for anesthesia and pain, it's also used for sedation as well. Another drug that we have is called Precedex, and this one has an unknown mechanism of action. This is a go-to alternative sedating medication in the United States. Alternative being alternative to propofol. If a patient won't tolerate propofol and we want to put them on something, we have quite a few options. We have benzos, and this is another option that we have. What do we use it for? We use it for agitation related to bipolar or schizophrenia, and in my experience, it's used more commonly for sedation in the ICUs. Adverse effects of this, just like almost all of the sedatives we had, hypotension. This one can cause bradycardia, not very common, but it can cause that. And again, a note, if you see that, make sure you're assessing your patient heart rate, blood pressure before, during, and after treatment. Patients may develop a tolerance to this, and they may need increasingly higher doses. Plus, when a patient's been on it for a while, they may have withdrawal symptoms as they come off of this. And again, this is an IV-only medication. Finally, we move on to the last section of this lecture, which is our paralytics. Our paralytics come in two varieties. We have depolarizing and the non-depolarizing. We'll start first with the non-depolarizing drugs. And the non-depolarizing ones include vecuronium, rocuronium, pacuronium, etc. And how do these work? These inhibit cellular depolarization. So in order for us to have a movement, in order for me to squeeze my fist right now, there's an action potential that's ready. When I give the command, it releases and I'm able to execute that action. If every cell is blocked from depolarizing, every cell is unable to execute that action, every cell is unable to move, and the patient's paralyzed. What do we use it for? We use it when we want to paralyze someone. For example, if we want to paralyze them to intubate them, to put an ET tube down their throat, that would be an example. Sometimes we may use this in the OR. Sometimes we may use this for a patient who's in status epilepticus, who we cannot control. It's refractory to any other treatment. Sometimes we use this as well. So there's a few different uses for it. These are considered among the absolute most high-risk medications in existence. Why? Because it paralyzes the entire patient. So if I paralyze the entire patient, they're no longer breathing. The diaphragm is the muscle of respiration. If it's paralyzed, the patient stops breathing anymore, you're not breathing, you die. Second of all, this medication, when it's given to a patient's completely paralyzed. However, this does nothing to treat their pain. So this patient absolutely can feel pain, and I can only imagine it would be extremely terrifying to be completely paralyzed, unable to speak, move, or anything, yet whatever other medical issue is still going on, whether that's why you're being intubated, whatever is going on, that issue is still ongoing. And the healthcare providers no longer see you screaming in pain because you're paralyzed, yet on the inside, I would imagine you still are. It's an extremely high-risk medication. It is labeled in every vial as a high-risk medication. Be really careful what you do with this. The medication, depending which one we're talking about, vecuronium lasts a little bit longer, closer to 60 to 90 minutes. Rocuronium is a little less, maybe 30 to an hour, but each medication has a different duration. You absolutely must know the duration of these medications, because as long as the patient is on this medication, they need to also be getting treated for pain and or sedation. Again, all this does is paralyze them so that you can do whatever procedure you're doing. However, something else needs to be done to turn the mind off, because the brain is still 100% working. This does not affect it in any way, shape, or form. This patient still feels pain. They still have anxiety, everything else. Those still need to be treated. There's no exception to a patient being given a paralytic and not also being given analgesia and or sedation. 100% of the time, they must get that. Any patient who is on a paralytic must be ventilated, whether that's with a bag mask or whether it's with an actual mechanical ventilator. They do need to be ventilated, because obviously they are not breathing, and that's on you. So we need to take over their respirations. This does have a reversal agent that we can use for this drug if we need to. And there's actually a few of these on the market, but this does have a reversal agent. One of them is listed here. Next, we have succinylcholine, which is now a depolarizing paralytic agent. So this is going to have the exact same outcome in terms of the fact that the patient is now paralyzed. However, it works completely differently. That last one, the non-depolarizing, this one blocked every cell from depolarizing, thereby blocking every cell from executing whatever command you are giving it. However, this one works the opposite. This one gives every single cell in the entire body the command to depolarize. And now every single cell in the body has to repolarize. And in the time it takes for every single cell to repolarize, no new action can occur. Thereby, the patient is being paralyzed. However, because of this mechanism of action, a few things to understand. So let me go over it one more time. In a patient that receives succinylcholine, it is going to depolarize every single cell in the body. And in the few minutes it takes for every cell to repolarize, those cells are impotent. They cannot move. They cannot execute an action. They are paralyzed. So a few things to consider here. First of all, what is this used for? We already know it's used when we want to intubate a patient. It's used when we want to possibly for the OR for a very short period of time, but almost exclusively this drug is used for intubation. Why? Because this drug, unlike the previous one, only works for a few minutes, because it's only going to work as long as it takes all the cells to repolarize. So really all it's good for is intubation. If we need any length of time that we need the patient to be paralyzed, this is not the option. We need to go to one of the non-depolarizing paralytics, such as rocuronium or vecuronium. This drug specifically, succinylcholine, has two adverse effects that are very well known, very common on tests, and make sure you know it, and that is hyperkalemia and malignant hyperthermia. How would you assess for this? Well, hyperkalemia, you monitor their labs. Also, you can monitor ECGs, because we know there are ECG changes that occur in a patient that has hyperkalemia. Secondly, malignant hyperthermia, definitely look out for a patient that's going to have muscle rigidity or fever, things like that, and know that malignant hyperthermia can occur within the first several hours or even a little bit longer beyond when the patient was given succinylcholine. I think up to 24 hours after, they can still develop that condition. Succinylcholine is the only non-depolarizing option. This is the only one that's only going to last for just a few minutes. It does have a unique aspect of it in that all the muscles, when they suddenly get that discharge, that they all get the command to depolarize, they can cause fasciculation, which is tiny little micro tremors that you can actually see on a patient. The biggest benefit to this drug is that it only lasts for a few minutes. Why? Because for as long as the patient is under this medication, they are not breathing. Now, if I gave a patient this medication in order to put a tube down their throat to take over their breathing, if I do a good job, great, then I took over their breathing, there's no problem. But if I fail, and now the patient is paralyzed, they can't breathe on their own, and I failed, so I can't breathe for them, they're screwed. So for that reason, it's a big benefit that it only lasts for a few minutes, because for a few minutes, I can just bag the patient until their own breathing takes back over again. And again, just like the other one, there's no excuse. Every single patient must get sedation and or analgesia if they are receiving this medication, because they can still feel pain, their mind is still on. So it is completely unethical to give this medication without also treating their analgesia and their sedation. Thank you so much for watching. Have a great day.